Hello from RSNA 2020. This is the Imaging AI in Practice demonstration from the first ever all virtual RSNA annual meeting. This is the Evolve with AI demonstration, and we will be your hosts for this video. Our names are
George Shee from Weill Cornell Medicine in New York.
Stacy O'Connor from the Medical College of Wisconsin.
And Walter Wiggins from Duke University in North Carolina.
Many of you watching this video are likely familiar with certain aspects of how data and information flow in a radiology clinical practice. In this demonstration, we look at how AI can help in different stages of the life cycle of an imaging study, utilizing a new type of system called an AI platform or AI orchestrator. In the radiology practice of the future, there may be many AI algorithms or models analyzing different exam types or the radiology workflow itself. An AI orchestration platform helps ensure the right data gets to the right model at the right time. We are going to walk through a scenario that you have probably experienced at your institution and show how it could be with a series of AI tools for assisted detection and workflow optimization.
The scenario we'll walk through involves a patient presenting to the ED for evaluation of stroke, who undergoes the typical workup, including 1. A non-contrast head CT on which early ischemia is detected. 2. A CTA of the head and neck that demonstrates a large vessel occlusion. And 3. A chest radiograph obtained in the ICU and subsequent chest CT obtained to better characterize an incidental lung nodule.
Thankfully, we were unable to find a single study with such a multitude of issues. So we created Frank-N study from several patients. The images may not line up perfectly, but hopefully you'll find this to be a relatable scenario that helps you envision how imaging AI could improve your practice. We begin with a scenario that we all experience many times each week. A patient has been brought to the ED via ambulance for evaluation of suspected stroke. The triage nurse calls in a stroke code and orders a CT head.
In the radiology department, the incoming order, CT head, displays on the Siemens Healthineers Singo Workflow SLR system. This system identifies this as an exam for possible stroke and has proposed the protocol CT head stroke code without contrast with CTA head and neck stroke code with contrast. The confidence level of the AI algorithm is displayed as color-coded bars on the right side of the screen. If they disagreed, the person protocoling the exam could have selected a different protocol from the full list. The protocoling radiologist glances at the patient notes from the ED and selects Accept button. Having AI suggest protocols saves time, which can really add up over the course of a workday.
Franken studies CT head and CTA head and neck are completed, and the scanner sends the images to Ombra Pax for permanent storage. Ombra Pax has also notified the Visage 7 enterprise imaging platform that a study is available to be read. Studies are initially put on the Visage reading work list at a normal level of priority. Often, studies are just read sequentially or in priority order, based on order parameters such as patient class, in this case, emergency. Ombra Pax auto-forwards the study to GE Edison OpenAI Orchestrator to let the system know there is a new study available for AI. The Edison OpenAI Orchestrator, in turn, directs the CT head without contrast and CTA series to the Siemens Healthineers AI RAD Companion system. Note that sometimes multiple algorithms can be run on a single exam. For example, the CTA could be sent to a stroke AI algorithm as well as an incidental lung nodule algorithm.
The AI RAD Companion Research Brain CT Stroke Assessment is run on the non-contrast head CT, starting with the hemorrhage detection algorithm. Since no brain bleeding is found, the algorithm assesses for changes of early ischemia and calculates an aspect score. AI RAD Companion then goes on to evaluate the CTA images for the presence of a large vessel occlusion.
The AI RAD Companion CT stroke assessment algorithm uses the RSNA common data elements to identify the question and answer pair. In this example, the question is, Is there a large vessel occlusion? And if so, where? You can see that the possible answers are different arterial segments of the intracranial circulation. The different AI RAD Companion stroke assessment algorithms will address various different question-answer pairs.
Since both early ischemia and a large vessel occlusion are detected by AI RAD Companion, immediate reading is indicated due to the critical time sensitivity of intervening with TPA and/or mechanical thrombectomy for acute ischemic stroke in the setting of LVO. AI RAD Companion sends the AI results to the GE Edison OpenAI Orchestrator. In turn, these results are distributed to the Visage 7 Enterprise Imaging Platform to reprioritize the reading of the study given the acute findings. The study is moved to the top of the reading work list. To get an overview of the study, the radiologist quickly scrolls through the non-contrast head CT. It is critically important for the radiologist to do this first in order to avoid AI confirmation or automation bias, where the radiologist might be unconsciously persuaded to confirm the AI result for a borderline finding, which could result in a false positive or a false negative.
After reviewing the images, the radiologist decides to review the brain hemorrhage results from Siemens AI RAD Companion stroke assessment. These results appear as another series on the right side of the screen. These images show the negative result for brain hemorrhage as a text marking within the image. The AI results for hemorrhage are negative with a 95% confidence reported.
The radiologist next reviews the aspect score calculations from Siemens AI RAD Companion stroke assessment. The brain segmentation again appears within Visage 7 on the right side as a separate series. The AI overlay can be toggled on and off. The AI aspect score results for the left and right sides of the brain are also displayed. As you can see, the AI algorithm found evidence of ischemic stroke in the left MCA territory and calculated an aspect score of 6 for that side. A couple of important points we should note here. One, when I interpreted these images independently, I came up with an aspect score of 9, taking away a single point for the loss of the left insular ribbon. Two, there is some variability in aspect scoring methodologies. Personally, I use a standardized two-slice approach to scoring published in AJNR that showed high reproducibility and inter-reader agreement. This may not be the method that the AI model uses. 3, looking at the model segmentation, I think two things may have contributed to the model giving a lower score than I did. 1, the scan is not reformatted in the true axial plane, resulting in baseline asymmetry between the two sides. This likely affected the score for the M1 and possibly M6 regions. 2, the model appears to have been fooled by partial volume averaging along the left sylvian fissure, affecting the score for the M2 region. I think these points really highlight the importance of the radiologist reviewing the scan independently to avoid introducing any subconscious bias. In this particular case, the difference between an aspect score of 6 and a score of 9 isn't clinically significant, but an aspect score less than 6 could prompt the neuroendovascular team to obtain additional imaging or even exclude the patient as a candidate for interventional stroke therapy.
Another important point here. The aspect score overlays shown here are a great example of interpretable AI results, giving the radiologist more insight into how the AI algorithm might have arrived at an aspect score of 6. Even though our neuroimaging expert disagrees with one of the AI results, the total package and implementation can still save valuable time, especially for non-subspecialists.
Those are great points. Moving on, finally, the radiologist decides to scroll through the CTA, again avoiding bias. First focusing on the MIP images to evaluate for possible large vessel occlusion or LVO. The radiologist noticed an abrupt vessel cutoff on the left concerning for LVO. Then they decide to review the Siemens AI RAD Companion results, which confirm the occlusion. Again, this is another great example of interpretable AI results, where we actually see the location of the vessel cutoff identified by the AI model.
There are distinct benefits of being able to modify the AI results before sending them to the report. It allows the tool to be helpful even if the radiologist disagrees with the AI result by integrating the results into the proper sections of the report, saving time and preventing transcription errors. This also provides structured data in the form of CDEs, which otherwise wouldn't be captured if the RAD simply rejected the result and dictated free text into the report.
The RAD accepts the Siemens AI RAD Companion no hemorrhage result, modifies the aspect score result to a 9, and accepts the positive large vessel occlusion, sending this coded information to the report.
The RSNA ACR informatics technology stack consists of report templates, common data elements, and a radiology lexicon, respectively named RAD Report, RAD Element, and RAD Lex. Using these building blocks ensures accuracy, completeness, and consistency. These building blocks are usable between modalities and regions of the body. While the report templates are aimed at a person reading the text, the CDEs and RADLEX codes are aimed at being computer readable and providing clarity when transmitting data between clinical systems and even translating text into other languages.
Let's see how AI can help implement the reporting stack and streamline the reporting workflow. The radiologist opens the M-Modal Fluency for Imaging reporting system with a correct report template based on the procedure code to dictate the reports for the head CT and CTA series.
As the radiologist is dictating the findings of the report, they note that the AI results, including ischemic stroke, modified aspect score, and large vessel occlusion, are already incorporated in the report. Some additional info and/or modifications may be needed for completeness, but overall, the process is accelerated significantly. And note that AI is not just for image data here. AI comes into play for the impression section too. When the radiologist states the word impression, the RAD AI software, which is integrated into the Fluency product, reviews the procedure information and findings and automatically generates the impression section. No duplicating of reading of findings, no transcription errors, improved report accuracy and consistency, and time saved.
Our patient, Frank in study, is admitted to the neuro ICU following successful interventional stroke therapy. While Frank is still in the ICU, a portable chest X-ray is ordered to evaluate a new cough. Similar to the head CT, the chest X-ray images are sent to Ombra and in turn to the GE Edison AI orchestrator, which then invokes Siemens Healthineers AI RAD Companion chest X-ray. Because there were no acute findings, the new chest X-ray appears as normal priority on the PACS reading work list. After quickly reviewing the chest X-ray and Visage, the radiologist gets a notification that results are available and decides to view these AI findings within the Siemens AI RAD Companion viewer. The radiologist sees a list of findings, in this case 2 nodules. The radiologist can then accept or reject these measurements. The algorithm also explicitly lists conditions which were not detected, such as pneumonia and consolidation. This confirms the radiologist's opinion that nothing else was found and increases their confidence.
As for those incidental lung nodules from the X-ray, the Philips Performance Bridge suite, and specifically their Followup Tracker, is able to analyze imaging reports, identify requests for a follow-up exam, and then flag the patient until a correct follow-up imaging order has been placed, making sure that potential findings do not fall through the cracks. So due to this alert, the team is reminded and places an order for a chest CT in 8 weeks. After Frank has been discharged and had a few weeks to recover from his stroke, a follow-up CT chest is ordered. The images are sent to PACS, the AI orchestrator, and then the Philips CT chest AI lung nodule detection and classification algorithm. The CT chest images are viewed on the Visage 7 imaging platform, first looking at the source images, then viewing the AI results which utilize the new DICOM segmentation object. The lung nodule was detected, segmented, and then classified by the algorithm. Now the radiologist selects the Philips AI lung nodule classification results to get a second opinion on the likelihood of the nodule being malignant. The results are either accepted or rejected on Visage and sent to the reporting system.
This lung nodule AI result is another great example of the use of a common data element, or CDE. This time, the AI will use the incidental pulmonary nodules on CT RAD element profile. In this case, the CDE question is, what are the characteristics of an incidental lung nodule on CT?
The classification of this nodule, as determined by the AI, is contained within the probability of malignancy, which conveys the model's estimate of the likelihood that the reference nodule is malignant.
Actually, all of the information from this Philips AI algorithm is machine-readable coded data. That's really important because the incorporation of CDEs into this workflow facilitates the direct integration of these AI results into the report and then into the EHR. And it streamlines future AI algorithm development by providing structured data to assist data scientists in evaluating the performance of the algorithm, which will then guide decision-making for future algorithm improvements.
So how are we going to keep track of how effective AI is in our daily practice, or if anyone is even really using it? How will departments be able to justify investments in AI technologies? Well, to be able to measure the effectiveness of AI, departments need to be able to log events using a standardized method to correlate points in workflow from different systems. The IHE Soul Profile provides a framework of standards for exchanging information about the business activities within a radiology department so that this information can be collected, analyzed, and displayed to derive and communicate new business insights for an organization. If the systems in your department adhere to Soul, you can measure the effectiveness of AI tools to improve performance measures like patient throughput, reporting efficiency, and follow-up of incidental findings.
The Philips Performance Bridge suite contains an application called Quality, which implements the IHE Soul standard. Using this product, the impact of AI, resulting in increased efficiency in critical results communication, can be demonstrated, and the value of AI be demonstrated to appropriate stakeholders. Let's shift gears a little and talk about setting ourselves up for success in the future development of AI technologies. Patients are increasingly aware of their personal and medical data being used for AI development, both for healthcare and in the broader tech industry. With products like Philips eConsent, patients are given the opportunity to release their imaging studies for the benefit of future AI development. The Philips eConsent platform streamlines the consent process and allows you to tailor its scope and limitations according to government regulations and institutional policies.
Moving on to the process of future AI development, there has been a lot of data generated from this patient's journey, including images, imaging metadata, and classification outcomes. And now is the time to get everything organized to be able to train and fine-tune AI models.
So, how do these AI algorithms work under the hood? Let's take a look. AI models themselves can be created using deep learning. Deep learning requires two components, an annotated data set and a computational framework. We use XNAT, an imaging informatics platform that manages images and other data for research purposes, and NVIDIA Clara to train and fine-tune AI models. Both NVIDIA Clara application framework and XNAT are open and can be downloaded for free.
First, we take Franken-Study's exam and add it to our overall imaging cohort. XNAT retrieves the study from the PACS so that a researcher can annotate it. Annotation of findings, such as occlusions or nodules, are used to train our AI models. NVIDIA Clara AI-assisted annotation helps the annotator to quickly highlight relevant structures.
But this brings up a really good point. If the common data elements had been used by the AI algorithms and during the reporting process, the images would already be annotated. This would dramatically increase our ability to improve AI algorithms.
Next up, we will use Clara Train to update the stroke model. The data scientist selects the annotated data set and appropriate training parameters to initiate a training job. This process uses accelerated hardware called the GPU to update the AI model. From here, this model can be validated and exported for eventual use in clinical practice. You now have an updated AI model. Using the model in clinical practice will require institutional oversight and possibly regulatory approvals.
Since we're about to wrap up, we should remind you that this is a demonstration of the future. As such, not all the products that you have seen in this video are yet released for sale. Some have 510K, FDA, and CE approvals, while others may not.
Thanks for listening as we walked you through some examples of how we can evolve with AI. Now go forth and discover new ways to implement AI in your practice.